So this is a 51-year-old female never smoker who presents with fatigue, chest pain, and low back discomfort, and is discovered to have a 4.5 centimeter right upper lobe mass with hilar adenopathy on chest x-ray, and confirmed on CAT scan. A diagnostic biopsy shows adenocarcinoma, and molecular testing, which at this point is standard in non-small cell, reveals FISH positivity for ALK-translocation. They've done the proper workup. In this day and age, this would include FISH testing for both ALK and ROS1, mutation testing, ideally next-generation sequencing, so we look not just for EGFR, but BRAF, HER2, c-MET, etc., and PD-L1 testing. And this patient, in fact, was PD-L1 negative, which is not uncommon. ALK positive, PD-L1 negative, EGFR positive, PD-L1 negative. Patient undergoes PET, which confirms lumbar spine metastases, which explains her low back discomfort, and also confirms stage 4 status. Otherwise, this patient would have stage 3 disease and would probably be best treated with a combined modality approach, but with bone involvement, local advanced type strategy makes no sense. So the patient is started on crizotinib, which is the standard agent in this setting. In the last 5 to 10 years, the standard approach for patients with lung cancer, specifically adenocarcinoma of the lung, is to interrogate the tumor on a molecular basis. Originally, we were looking for EGFR mutation. That's now expanded. We look for EGFR mutation. We look for ALK or ROS1 translocations, and we've added other mutations or other molecular aberrations to that list, including BRAF, HER2, c-MET, etc. So the best approach, particularly in a patient who's not terribly symptomatic, who has the luxury of time of at least waiting for these tests to come back, is to simultaneously do next-generation sequencing for an array of mutation markers, to do FISH, specifically for ALK, ROS1, and to some extent RET. And now, in the face of approval for immunotherapy upfront, specifically pembrolizumab, which has shown superiority to chemotherapy in individuals with PD-L1 expression 50% or higher, PD-L1 testing is also part of the mix. Now, that's an IHC test. So we have a mix of tests that we're doing, next-generation sequencing, FISH, and IHC for PD-L1. So it's incumbent on the clinician to make sure we have sufficient tissue to do all these tests, and that's sometimes the biggest challenge.